Okay, so picking up where I left off, I want to introduce the term culture-bound syndrome. Cultural anthropologists, Arthur Kleinman, most prominent among them, played the foremost role in mobilizing the notion of culture-bound syndromes amongst psychiatrists in particular. We saw this concept appear in DSM-4 as a concept in DSM-4 in 1994. A culture-bound syndrome is, according to DSM-4, a locally specific aberrant behavior that may or may not correspond to a DSM diagnostic category. But these do tend to be thought of on the local level as illnesses. An example of this from my own field site, I work with American Indians who do purification rituals for veterans. They don't really use the language of PTSD, but they have a term, Iwayazanazuyeya, which translates roughly as the sickness that one acquires from fighting with people and the self. Arthur Kleinman in DSM-4 would call this a culture-bound syndrome. Not every culture has this concept of a literal illness that one acquires while fighting with people. Um, but DSM-5 changed this. In DSM-5, the culture-bound syndromes were done away with. And what DSM-5 said, they have a section where they explain why. And they say the term culture bound syndrome ignores the fact that clinically important cultural differences often involve explanations or experiences of distress rather than culturally distinctive configurations of symptoms. Furthermore, the term culture bound overemphasizes the local particularity and the limited distribution of cultural concepts of distress. Um, Note here the APA is speaking to anthropologists. Anthropologists and anthropological theory played the largest role in introducing the notion of culture-bound syndromes into the DSM. In other words, the APA is saying that the term culture-bound syndrome is relying too much on abstract descriptions of distress rather than configurations of symptoms. I'm reminded of a quote from Foucault from The Birth of the Clinic concerning the process that we've talked about of medicalization. And Foucault said, physicians stopped asking what is wrong and they started asking where does it hurt. And I think that's what's happening here. The APA is basically defending increased medicalization and are saying that the culture bound syndrome term derives from asking people what is wrong, while we should be asking them where does it hurt. Also, the APA is arguing that it's a mistake to believe that human experiences of pain and distress are as locally specific as the notion of a culture bound syndrome suggests. Um, I would go so far as to say, understanding the history of this debate, that the APA is saying um, anthropologists are arguing that the experiences of pain and suffering and distress are much more variable than we, the psychiatrists, maintain. So DSM-5 goes on to argue that they do believe that culture inflects the experience of distress. And I note that psychiatrists like to use the word distress while anthropologists like to use the word suffering. I don't know if that's meaningful, but it's something I've observed. DSM-5 goes on to argue that culture does inflect the experience of distress, and it can do so by doing things like conflating several DSM categories into one folk concept. Likewise, diverse presentations that might be classified by DSM-5 as variants of a single disorder might be sorted into several distinct concepts by an indigenous diagnostic syndrome or system, and that's a quote from the DSM. So the DSM goes on to emphasize the importance of what in our class we've called cultural competency. They state cultural variation may cause clinicians to misjudge the severity of a problem. Clinicians might judge someone to be experiencing psychosis who's simply describing their experience in local spiritual terms. And speaking the language of the patient both linguistically and in terms of his or her dominant concepts or metaphors can result in greater communication and satisfaction, facilitate treatment negotiation, and lead to higher retention and adherence. In other words, it's a very classic case of emphasizing the cultural competence approach. Become more competent in understanding local culture, and if you can speak that language, you can get the people to do what you're trying to tell them to do. So I'm going to move on and talk about our other reading from Tanya Luhrmann of Two Minds. Tanya Luhrmann is a medical anthropologist at Stanford, and she did her original fieldwork on magic and witchcraft, things like the notion of God and the experience of the supernatural. But this book of Two Minds, I know that I didn't assign the entire book for you to read, but I hope from the reading that I gave you that you can get a sense of what the two minds are. The two minds that she's referring to are basically two different approaches to psychiatry. Note that she was doing her fieldwork for this book in the late 1980s and in the 1990s during the meteoric rise and expansion of the use of pharmacological intervention in psychiatric patients. So this goes back to some of what we talked about in the evolution of the DSM. When she was doing her fieldwork in the 1990s, she felt like there were basically two competing ideologies of psychiatry. There was the psychoanalytic model and the biomedical model. I think she calls these the psychodynamic model and the biomedical model. You might say that when she was doing her fieldwork, that there were still a whole lot of psychiatrists still using what we might call DSM-2 approaches towards psychiatry. Psychoanalysis advocated the use of talk therapy as the primary intervention provided by psychiatrists. On the other hand, there were increasing numbers of psychiatrists using more of a Kraepelinian method, viewing mental illness as a disease to be treated with medicine. So some people who have read this book, or a common opinion that one gets about this book is the impression that Tanya Luhrmann herself was of two minds. You get the impression that she knows that there's something problematic in the theoretical base of psychoanalysis, but it kind of seems to just like it better in some ways. If you read the whole book, you learn that she came to this project by becoming a professor at Stanford. She found herself in a department with a psychoanalytic focus. And I'll say this, that psychiatrists and psychologists might have left Freud behind a long time ago, decades ago. But as an anthropologist, I can say that there's still a lot of anthropologists who are clinging to Freud pretty tightly, and that's what she was encountering when she went to Stanford and got interested in this project. So what we see in this chapter basically is two different kinds of hospital. She talks about the biomedical ward and the psychodynamic ward. So what are the things that constitute these different wards? As I read this, I wondered if the distinctions were what she thought there were. There are so many moving parts. Of course, there are different theoretical orientations of the different wards, and that's important. But there seemed to be a lot more going on too. The psychodynamic hospital seems to think of human behavior as existing on a spectrum, which is psychoanalytic. All of us are different, and we are sick when certain behaviors move us into the extreme ends of the spectrum. The biomedical unit tends to think of all humans basically as psychologically similar and very rational. We all contain a rational thinking adult in us who behaves in standard and predictable ways. And some of us experience illness and injury to our brains that cause unwanted behaviors that cannot be properly attributed to the rational person or their experiences themselves. So what else was going on in these wards that might have contributed to the health, the efficacy, the effectiveness, and organization? We do see for sure that there is some difference in the socioeconomic status of the patients, the insurance policies, the hierarchical dynamics. There's so much going on with that. Physicians and psychiatrists, nurses, social workers, psychologists, etc., were all competing for influence, and the pay was very different for these different people. Um, I noticed the differences between the two biomedical units she described. One sounded much more chaotic than the other, and I noticed that the number of patients housed in the second unit, the psychodynamic unit, was lower. And it also sounded like the clientele there were of the professional class, a lot of professors, scientists, doctors, etc. Um, and she talked a lot about things, laughter, which we've talked about with um, some other things in the class. And there were a few different things I wanted to point out from the reading that were just some interesting things there. There was the one doctor who was being trained in psychoanalysis, but then turned away from it when his friend had a psychiatric episode that was not relieved until they came under pharmaceutical therapy, and then it did. They did experience relief, and that convinced this doctor that the brain is the actual source of a lot of the things that they were trying to treat, rather than unconscious drives. Um, there were things like drawing a line between the patient and their illness. That's something that we saw more in the biomedical ward. They saw the mental illness that these people were experiencing as being something separate from them as people, which is very different than what you see in the psychodynamic ward, where these things were seen as much more connected. So managing a patient um, involves trying to determine the difference between the desires and needs expressed by the patient themselves and the things that were expressed by the disease. That's in the biomedical ward. Um, and it I felt like there was some creepiness to the whole, like, you are not seen as well until you admit that you're sick dynamic, which she explained on pages 140 or 141. Um, the patients in the psychodynamic ward, they're upper middle class, but ironically, their treatment is much cheaper over the long term. And again, there were parts where the environment seemed a little better. They're a little less chaotic, but at the same time, who had access to that? And what do we do with the fact that some of the theory has just been proven to be obsolete in some ways, and that's why psychiatry has been moving in the direction that it has been, which is in the direction of biomedicine and away from theory-based nosology. Things have changed since this book was published. Like I said, this is based on field work that is 30 years old. And even then, when she wrote it, the psychoanalytic school was losing its influence in psychiatry. And today, um, it's very much a biomedical discipline. I'm going to stop this here, and I will start to talk about PTSD in the next video.